Well, good evening, everybody. Thank you for joining the webinar. Karen Marchand and I are going to be talking tonight about updates in prenatal testing. My name is Barbara O'Brien. I'm one of the maternal-fetal medicine geneticists at Beth Israel Deaconess Medical Center. And Karen Marchand is the senior genetic counselor at BI who works very closely with myself and Dr. Ferris, who's also an MFM geneticist, and the other prenatal genetic counselors here at Beth Israel. Next slide. We have no financial disclosures. And the objectives of today's talk are, we are going to review the detection rate and false positive rate of cell-free DNA for aneuploidy. We'll discuss the various abnormal cell-free DNA results and implication of those results. We'll review the use of cell-free DNA screening for non-aneuploid conditions and the use of microarray in prenatal diagnosis. And finally, we'll review the use of whole exome sequencing in prenatal diagnosis. First, we'll review a case of a 33-year-old gravida 4, para 1 patient who desires aneuploidy screening. So what is appropriate to offer her? So we'll circle back to this case after we review some things about terminology and also detection rates of aneuploidy and various things like that. So before we begin, just a note about terminology. Non-invasive prenatal testing, or NIPT, is really a catch-all phrase that includes first trimester screen, integrated screening, quad screening, nuchal translucency. All of these are all, quote, non-invasive prenatal testing methods. Cell-free fetal DNA, which is the term that you'll hear me referring to throughout the talk, is circulating placental DNA that's used for fetal aneuploidy screening. Placental DNA is most of the time fetal DNA, but not always. Cell-free DNA is circulating DNA that's not contained within a cell. Although not entirely specific to prenatal screening, we'll use the term cell-free DNA within this talk. So just to review a brief history of cell-free DNA, this is relatively not necessarily a new concept. So in 1890, Schmorl et al. Found that placental cells were actually in the maternal lungs in women with eclampsia. In 1947, cell-free DNA were isolated from the blood, and they were found to be higher in cancer patients. And as you may know, this is actually being investigated in cancer patients currently for treatments. In 1990, Dr. Bianchi et al. Found that intact fetal cells are found in the maternal circulation. And then a landmark study by Dr. Dennis Lowe et al. Found that cell-free fetal DNA was found in the maternal circulation. And this was really groundbreaking and a proof of concept paper. And then Dennis Lowe in 2010 found that the entire fetal genome can be sequenced from the maternal circulation. Okay, so both the maternal and fetal placental units produce cell-free DNA. The primary source of fetal DNA is thought to be apoptosis of the placental cells, or the syncytial trophoblasts, while the maternal hematopoiesis is the source of most maternal cell-free DNA. A lesser source is apoptosis of fetal red blood cells that cross the placenta and enter the maternal circulation. Differences between the placental and fetus are important sources of discordant cell-free DNA test results that we'll talk about in a little bit. Next slide. Okay, so there are multiple methods for detecting cell-free DNA, and it can be an entire talk in and of itself, but let's suffice it to say that there are three main methods. Here at BI, we have chosen to use the SNP-based method, or single nucleotide polymorphism method, and the company we use is Natera. SNP-based methods uses tens of thousands of highly polymorphic SNPs located on the chromosome of interest. Maternal SNP genotypes of interest are then inputted and compared with corresponding genotypes of the mixture of cell-free DNA from the mother and fetus in the placental sample. Other methods for detecting genomic contributions from specific chromosomes are massive parallel shotgun sequencing and targeted sequencing. But like I said, we use SNP-based methods. Basically, all these different methods do have very similar detection rates and very similar false positive rates. So if you're using a different company, the detection rates that I'm going to be quoting a little bit later in the talk are very similar. Next slide. So some considerations. The SNP-based methods can be used to determine zygosity of twins, vanished dizygotic twins, and triploidy. The SNP-based method should not be used with patients having donor bone marrow or organs. And the SNP-based method should not be used in these scenarios and samples because there are other confounding chromosomes in the maternal plasma. Okay, so how does cell-free DNA perform for aneuploidy? So it's an excellent test for aneuploidy, as we all know. So the detection rate for trisomy 21 is excellent, upwards to 99%. And all of them have very low false positive rates. For trisomy 18, it's about 97 to 98%, a little bit lower, but still excellent for trisomy 13. And this data comes from all types of sequencing, so targeted sequencing, massive parallel shotgun sequencing, and the SNP-based method of sequencing. And this is on high risk and low risk populations, okay? All right, how do we do for sex chromosome aneuploidies? So we do well, but not as well for the for Down syndrome, trisomy 18 and 13. So for monosomy X, the detection rate is about 90% with a very good false positive rate. And for the other sex chromosome aneuploidies, so 47XXX, 47XXY, and 47XYY, the detection rate is about 93%. Okay? So the cell-free DNA performs less well for the sex chromosomes. So we always hear about the importance of fetal fraction. So just as a reminder, what fetal fraction is the percentage of cell-free DNA in the maternal plasma. So multiple factors can reduce a fetal fraction, and we need a certain percentage of fetal fraction in order to get the result, and that's about 4%. And if we don't have sufficient fetal fraction, we're not going to be able to get a test result. So the factors that can reduce the fetal fraction are early gestational age, so if you draw the sample too early, obviously suboptimal sample collection, if a patient's weight is increased, so an increased BMI, placental and fetal karyotype, so if you have an aneuploidy, that can decrease the fetal fraction. Certain patient health conditions, so conditions with high cell turnover, such as sickle cell, malignancy, we'll go through a couple others later on, and then medication treatment. So if a patient's on Lovenox, that can also decrease the fetal fraction. Okay, so we do hear about false positive cell-free DNA results. So how can we get false positive cell-free DNA results? The most important concept to consider is something called confined placental mosaicism. And this is when the cell-free DNA result from the placenta can differ from the fetus. And so it's higher in babies with trisomy, or higher in cases with trisomy 13 and sex chromosome aneuploidies. And so in this case, that's higher. For other sequencing methods that are non-SNP based, you can have maternal cell-free DNA abnormality. So mom has an aneuploidy or mosaic aneuploidy. Certain tumors like fibroids and malignancy in moms. You could have a vanishing twin, and that twin is giving off an aneuploidy signal. You can have copy number variants in the mother and malignancy in the mother as well. Okay, next slide. All right, what about false positives and fetal sex prediction? So if you have a low fetal fraction, the Y chromosome fragment may be missed. And so that's why you could have a false positive fetal sex prediction. Another couple reasons why you could have fetal sex prediction with false positives is in the case of a transplant recipient. So if you obtain the transplant from a male donor and the cell-free DNA may be incorrectly identify a female fetus as male due to the male cell-free DNA from a donor, if that makes sense. Also, if a patient has a recent blood transfusion, the blood transfusion from a male donor given less than 4 weeks prior to drawing the cell-free DNA testing may also lead to a false positive. Okay, so interesting. Next slide. All right, what about test failure? So a test failure basically is if you draw a cell-free DNA test on a woman and it comes back as no result or a test failure. And that's overall estimated to be about 2% of all cases. Reasons for this is a low fetal fraction. Like I said, you need to have about 3 to 4% of circulating cell-free DNA in the maternal plasma to obtain results. Reasons for a low fetal fraction, again, are an increased BMI or an increased weight, actually, early gestational age, suboptimal sample collection, an abnormal fetal karyotype. So if you have an aneuploidy, that can lead to actually a low fetal fraction, particularly trisomy 13, trisomy 18, triploidy, and Turner syndrome. Any state where you have maternal states of high cell turnover, like sickle cell and cancer, that in and of itself can lead to a test failure. And also in cases of consanguinity or something called uniparental disomy. And those, what that is if you inherit or the fetus inherits both alleles from one parent. All right, so we all know that the positive predictive value decreases with lower age or prevalence. So the detection rate and false positive rate for aneuploidy with cell-free DNA are unlikely to differ between the high and low risk populations. What does change, and which is very important, is the positive predictive value, which depends on the prevalence of the disease in the population. So to demonstrate this, the next 2 slides are going to give you an idea of how this can differ because of maternal age. And it's not necessarily the age of the patient, it's the prevalence of the disease in the population based on the age of the woman. So next slide. And this comes from the National Society of Genetic Counselors. And you can actually look this up on the National Society of Genetic Counselors site. So this gives us the positive predictive value of a woman who is 40 at EDD. And so it says the prevalence of trisomy 21 at 16 weeks gestation for a woman who is 40 at EDD is 1 in 86. So the probability that the result is a true positive, so that the fetus is affected, or the positive predictive value is 93% in a 40-year-old. And the probability that there's a false positive and the fetus is not affected is 7%. Okay, so that's a 40-year-old. Next slide. This is a 21-year-old. So the positive predictive value is only 49%, and the probability that there's a false positive or the fetus is not affected is 51%. So you can see these dramatic differences based on age, which is really based on the prevalence of the disease in the population between a woman who's 40 and a woman who's 21. All right, so a lot of the testing companies now are actually giving the positive predictive value on the screening report that you get, on the result that you get. Okay, so remember, the detection rate is very, very good, and the positive predictive value really varies depending on the prevalence of the disease in the population based on age. The negative predictive value is the same for both. It's excellent. Okay, next slide. I'm going to have Karen explain this. This is a nice pre-test counseling checklist that you should go through with all of your patients prior to them having cell-free DNA.
Great. Yeah. So pre-test counseling, I think, is really, really important and can really clarify expectations for the test and create a much better understanding once the results are communicated after the test is complete. SMFM does provide this checklist. I think the elements that are the most important are that the testing should be considered elective. So patients should feel very comfortable declining the testing if they don't feel that it would be helpful to them or might create greater anxiety. Certainly, I've seen patients who just felt it was expected, that it was sort of a checkbox for their provider, that this is something that everybody did, and who did not understand that it was actually an optional testing strategy. Also the scope, so what conditions are going to be included. I've seen patients who thought the testing was only for Down syndrome or only for fetal sex. And I've also seen patients who thought it was for all chromosome conditions and didn't understand the scope. So that's very important, reviewing the limitations, what it cannot detect, and the potential for false positives and false negatives, the accuracy, the availability of diagnostic testing, either as an alternate test strategy or in the setting of a high-risk result. And then also, I like to clearly review with the patients the 4 possible results they could get back from cell-free DNA screening. So that would be high risk, low risk, and I tell them that that would imply less than 1 in 10,000 residual risk for those conditions. And no result. And we talk about here's what we would do in the setting, in the situation where there's no result. And then an atypical finding. So a finding that is not clearly normal or low risk, but falls outside of the scope. It's not one of those specific trisomies, or at least not in all of the cells. And we talk through those various, and those can be, they can be atypical findings related to the fetus, or they could also be atypical findings that the lab has noted in the maternal DNA. So if we move to the patient, that case number 1 patient. So that patient was offered cell-free DNA screening as an option. Depending on her specific characteristics, she may have been offered first trimester combined screening if there was, for instance, a high risk for failure with the cell-free DNA, or something about her history that would make that a better test for her. This patient did do cell-free DNA screening and got an atypical finding result, so that 4th category that I mentioned. When you get an atypical finding result, usually, at least with Natera, usually they will specify on the report whether it was suspected to be of placental and therefore potentially fetal origin, or whether it is of maternal origin, or whether that can't be differentiated. They also will usually suggest which chromosome is involved and what type of abnormality, whether a copy number variant was suspected, so a deletion or duplication, or whether mosaicism might be suspected. So you always have to read these reports. And in this case, it says that an atypical finding suspected to be of maternal origin was detected, and that studies on pregnant patients with similar results suggest increased likelihood for maternal health issues, to include potentially maternal neoplasms or maternal chromosome abnormalities. And so reading between the lines, this tells me they saw multiple aneuploidies in this specimen, which is something that is certainly suggestive of malignancy. This patient met with a genetic counselor at 16 weeks to review this result. The family history review, which we do for every patient, was significant for colon cancer in a maternal uncle and colon polyps in the patient's mother and brothers. So certainly suspicious for a hereditary predisposition for cancer. As it turned out, the patient had had a breast and lymph node biopsy due to finding a lump that was performed 1 week prior to the genetic counseling visit. And the pathology report actually became available later that day and showed that it was an invasive ductal carcinoma. So the patient was referred at that point for oncology. treatment and discussion. So the other consideration here is that because of the way this was reported, essentially no aneuploidy screening had occurred. And so she was offered alternate options for aneuploidy screening, so quad screen and amniocentesis, and declined on the basis of the reassurance provided by the nipple translucency measurement. So now we're going to change gears and talk about the use of cell-free DNA screening for conditions other than aneuploidy. And we're going to start by talking about a few different tests that are available that we actually do not routinely use in our clinic. So the first would be screening for status. So this is something that has been fairly commonplace in various European countries for actually quite a bit of time, but has not been something that is commonly performed in the US. Various labs have had this test available, not had this test available, but in the US, it's always been a self-pay, non-reimbursable type of testing. And part of the reason for that is that the way the testing was performed previously, it does not perform equitably across different ethnic backgrounds. So there's certainly a better performance in individuals of European ancestry compared to minority ancestry backgrounds, related to the differences in the Rh gene that are found. So the latest iteration of this is through a company called Billion to One, and they launched their Unity fetal RHD screen in 2020. And at that time, it was just RHD only. They use a different technique that they call quantitative counting template technology. And with this testing, they do sort of get around the insurance issue by requiring that a provider order aneuploidy screening simultaneously. So they bill for the aneuploidy screening and then release results for both the aneuploidy screening and the Rh status. So this is what one of those reports looks like. So the top part is fairly typical cell-free DNA aneuploidy screen results. And then at the bottom, they show the RHD status, which for this fetus, they reported it as likely positive. One tricky thing here, they actually do not provide a PPV, a positive predictive value. I couldn't find one anywhere in their information on their website. And this company has not been the most transparent. They have, I think, for a long time been operating where they offer tests but actually didn't have any published data on the tests they were offering. So that's one concern about this testing. And then much more recently, they expanded this to other red cell antigens, as you can see. And they did just publish in the past year, so it was a combination of preclinical study where they used lab-created sort of artificial specimens made to sort of mimic what they would expect to see in actual patient specimens, as well as some actual patient specimens where they didn't know the outcome, and some biobank specimens, so true patient specimens, but where the outcome was known. And they showed really quite good performance, however, just really small numbers. So it will be important to see this replicated. Also, I know other companies are looking into launching their own tests like this as well. So this is sort of an evolving field. ACOG still says that the standard of care for Rh negative patients is to provide RhoGAM, and that the standard of care for other alloimmunized patients is to perform partner typing and then offer amnio as needed, and treatment, of course. So when might this be used? So certainly if there is a patient who has sort of moral or religious reasons for not wanting RhoGAM, that might be a patient if they are willing to accept the small potential for a false negative result, where you could use this test, or in an alloimmunized patient who does not have a partner available to participate in the testing or who wishes to avoid amnio, again, understanding the very small risk for a false negative result and what the consequences of that may be. This same company also has a carrier screen product. So this product, they do routine traditional carrier screening like happens in other laboratories for the pregnant person, followed by single gene cell-free DNA analysis if the patient is determined to be a carrier. So they do not use the partner's sample at all in this analysis. And they do this for CF, SMA, sickle cell disease, and thalassemias. And at the conclusion of testing, if the patient is a carrier, they provide a numerical fetal risk estimate where anything higher than 1% is determined to be high risk, anything lower than 1% is reported out as low risk. And so this is what this one looks like. So the top part is the carrier testing on the left. So it shows the conditions and the maternal carrier status. So in this case, you can see this patient was determined to be a carrier of cystic fibrosis and has the common Delta F508 mutation. And then they show on the right that they did fetal single gene NIPT for cystic fibrosis, which came back a low risk. And down below, you can see that it's reported as 1 in 2,800 chance for the fetus to be affected. And this test they have been doing for a couple of years, and they did just Pember. And what you can see from this data is that providers are using this in a targeted way. So across the patients that they tested, almost 18% of them were carriers of one of the included conditions. So it shows that providers who are using this are using it likely, for the most part, for patients who have already been determined to be a carrier through other testing. Certainly some providers are using it in a routine way, but not all of them. And they did follow up on, unfortunately, only 528 of the cases with only 25 affected. And so we know that the sensitivity and the specificity definitely seem promising, but really wide confidence intervals related to the small sample size. Also, the average PPV was 50%, so not fantastic. Again, with a wide confidence interval. So this is a test that potentially is more useful as a screen when it comes back negative for the fetal status than when it comes back positive. So when might we use this? So again, really careful counseling about pros and cons and the screening nature of this, but potentially for a patient who's been determined to be a carrier and has an unavailable partner or a partner who's not willing to have carrier screening, a patient who really wishes to have more information to use into their decision making as far as whether to consider diagnostic testing, or a patient who knows they do not want diagnostic testing, but they are looking for some additional fetal risk assessment likely in the hopes of gaining reassurance. And again, they would need to be counseled carefully that it may actually increase their anxiety and whether that may be a good idea or not. One other thing to mention about this company and their screens, they very recently, in I think October, started a direct consortium of testing as follow-up to their aneuploidy screening. So what they've started doing is a test called Baby Peak. And basically what they're doing is using the clinic provided blood sample from the patient and looking at markers that inform things like hair color, eye color, whether they like cilantro, when their baby teeth might come in, all of these little elements. And basically they contact patients directly and say, hey, if you want to send us $100 or whatever it is, we'll send you some extra information. And so they're not involving sort of providers in this, and really direct to consumers. So a lot of ethical concerns with that testing on their part. So that's something they have started doing. So now we're going to move more into cases and tests that we do perform much more frequently. So case number 2, this is a prima gravida patient seen at 21 weeks gestation. And I should mention all of these are actual patients we have seen. 21 weeks gestation after her fetal anatomy survey. And on the anatomy survey, there was bilateral urinary tract dilation with possible horseshoe kidney, hypoplastic versus absent CSP, possible heart defect, brachycephaly with low set ears, single umbilical artery, and polyhydramnios. So a lot of different concerns that would raise concern for aneuploidy or genetic condition in the fetus. As far as history, this is actually the second time this patient saw genetics in the pregnancy. The first time was for a borderline increased nuchal translucency of 3 millimeters in the first trimester. And at that time, she declined CVS and opted for cell-free DNA, which returned low risk, and expanded carrier screening, which was negative. So after these new findings, the patient was offered amniocentesis, of course, but also was offered Vistara. So we're going to talk about this Vistara test. So Vistara is a form of single gene cell-free DNA screening and looks for about 25 conditions across 30 genes. And these are primarily autosomal dominant conditions, but there is also X-linked condition. And some of the more common ones that you might be familiar with are achondroplasia, Noonan syndrome, tuberous sclerosis, thanatophoric dysplasia, CHARGE, Cornelia de Lange, Rett syndrome, and osteogenesis imperfecta. And altogether, the 25 conditions they've selected have a combined incidence of about 1 in 625 pregnancies, so fairly similar to the population incidence of Down syndrome. The turnaround time for this cell-free DNA screen is a bit longer than for the aneuploidy screening. It's about 3 weeks. And the fetal fraction that's needed for results is a little bit higher since it's much more of a deep sequencing technique, more difficult. And Natera has published a couple of papers. So their initial paper in 2019 was fairly small. And in this paper, they didn't see any false positives or false negatives. They published a much larger sample more recently. And they found, again, that no false positives and no false negatives. So that's not to say that there won't be any. I actually do know of false negatives in particular. I think we worry more about false negatives than false positives with this. And there also are some incidental diagnoses and maternal diagnoses made through this testing as well. So this is what this patient's result looked like. So she did opt for both amniocentesis and Vistara. The reason we selected to offer this patient Vistara was because of findings that raised suspicion for Noonan syndrome. And in fact, that was the diagnosis that was made. So the Vistara showed a pathogenic variant in the PTPN11 gene, which is the most common gene you see variants in individuals with Noonan syndrome. And so she was counseled that it is very likely that this fetus has Noonan syndrome. And she opted to use the amniocentesis specimen to confirm that. So the specimen was sent, the finding was confirmed, and it was determined to be de novo, so to be brand new in the fetus and not inherited from one of the parents. Noonan syndrome is very common. It's about 1 in 1,000 people and has a pretty wide spectrum of manifestations. So we have identified it in parents who did not know they had it in the process of diagnosing it in a fetus. So in this case, it was determined to be de novo, which is really important for recurrence risk counseling. The next case is a 23-year-old prima gravida seen at 24 weeks for long bone abnormalities on her fetal survey. So specifically, the femora were short and curved with question of an angulation or fracture, and there was also a left club foot. The pregnancy history was unremarkable, but the family history was notable for her partner having bilateral club foot, as did his sister and mother. So presumably an autosomal dominant clubfoot predisposition in that family. There was no known consanguinity, and she had previously had a low-risk maternity 21 cell-free DNA and negative carrier screening. So she was offered amniocentesis as well as Vistara, to there being several different skeletal dysplasias on the Vistara panel. And then she was offered more expanded carrier screening than what had been done initially. She opted to do the Vistara and the Horizon 274. She declined amniocentesis, stating that it would not change her pregnancy decisions. So her Vistara result is also screen positive, but it's a different flavor of screen positive. So it's always important to read the fine print. So in this case, a variant that's classified as a likely pathogenic variant. So what that tells us is there's less data on this variant as compared to the other one. In the COL1A2 gene was detected in the plasma from this specimen at a level consistent with its presence of a maternal variant. So in this case, they've diagnosed the mother as having this variant. And so the report is screen positive because diagnosing the mother implies 50% risk for an affected fetus, since this is a dominant condition, and they view 50% as being high enough to be screen positive. And then at the below, there's some information about the variant and the fact that it's been seen in a couple different people with some presentations consistent with osteogenesis imperfecta. So in this case, she was counseled that, so she, I should say, has zero symptoms of osteogenesis imperfecta. She played sports in her teens. She did not have excessive fractures. She didn't have loose sclera. She really didn't have any symptoms consistent with that diagnosis. So that would raise suspicion that perhaps she's mosaic for that variant. I think we're also learning, though, that perhaps there's more variability in OI than we previously appreciated, because I know that in clinics that are ordering Vistara more regularly, they've actually seen several maternal OI variants detected. So when to consider ordering Vistara? So definitely there are some clinics that are offering this as a routine part of their screening. I think most are not, but certainly some are. And I think it's just sort of weighing that 1 in 625 sort of incidence of these conditions versus the potential for false positives, false negatives, incidental findings. And for me, I don't feel like there's quite enough data yet for me to feel like it's something that I would want to offer routinely, but that data will come, certainly. So in our clinic, we offer this when there's been a prior child affected with a de novo condition. In that situation, there's always a low risk for gonadal mosaicism and recurrence for that reason. So this is a good tool to use for those families. In situations where the sperm contributor is affected with one of the conditions. So I would say this is most likely, we've seen patients who have partners with achondroplasia or a partner with tuberous sclerosis. This can be useful in those situations. We would also offer diagnostic testing in those situations. Suspicious, I should say it can't be used if the mother is affected. They really cannot do any fetal risk assessment in the setting of an affected mother. They're really looking for variations different from the background, which is the mother. Suspicious ultrasound findings, so not every ultrasound finding, but those that would raise suspicion for one of the conditions that's included. So primarily we're using this for fetal growth restriction in short long bones, particularly in the 3rd trimester, which could represent achondroplasia. Increased nuchal translucency or cystic hygroma, which raises suspicion for Noonan syndrome spectrum disorders, and some cases where there are multiple anomalies. We do offer this to patients who voice particular anxiety about advanced paternal age, since that does pose some increased risk for dominant conditions, de novo dominant conditions. Although it should be said that Natera's published data did not show a high incidence of these, a high yield it for that indication. And kudos to them for publishing that, even though that was their primary marketing tool to begin with. And then, I do personally, if a patient is asking me or telling me they want to do every possible screening test, and is there another screening test, I will bring up the option of Vistara in that situation. And so we're going to now sort of move away from the screenings and towards more diagnostic types of testing. So first we're going to talk about microarray. And microarray is something that is offered anytime we do invasive diagnostic testing. So we'll start with a case. So case number 4 is a prima gravida patient seen at 12 weeks gestation who had an increased nuchal translucency measuring 3.1 millimeters. She was offered options of cell-free DNA plus or minus amnio based on those results versus CVS. And she opted to do CVS and therefore was offered microarray.
Okay, great. Thank you, Karen. That was excellent. So just a little bit of background on microarray to remind everybody. So a standard karyotype is able to detect large, extra or missing chromosomes, for example, Down syndrome. A microarray is able to detect small deletions or duplications of genetic material, for example, 22q11 deletion syndrome. It identifies copy number variants. It detects an abnormality in about 6% of fetal anomalies with a normal karyotype. It does not require dividing cells, and the population prevalence of variants of unknown significance, so where you aren't quite sure if the deletion or duplication is pathogenic, is about 1 to 2%. So the chance for copy number variants leading to a genetic syndrome does not change with age. So unlike aneuploidies, a duplication or deletion is not age-related. We discussed the option of a microarray with all patients who opt for prenatal diagnosis. So all patients who opt for a CVS or amniocentesis. Most patients doing a procedure for anomalies accept microarray. The acceptance is variable for other indications, such as AMA. A microarray is standard of care for the evaluation of the genetic cause of stillbirth. It's not always covered by insurance in the absence of anomalies, but when we do prior authorizations, most of the time I would say it is. Next slide. Okay, so variants of unknown significance, like I said, is present in about 1 to 2% of cases. Genetic changes may or may not cause disease. So the parental samples are sometimes needed to help kind of suss that out. We do, based on a microarray, have the ability to identify adult onset diseases in asymptomatic parents, and it also can identify consanguinity. So I don't expect you to read the box on the right, but I'll go over some points. And this sample script for counseling patients before a microarray came from SMFM. And basically, it says that chromosome microarray is a genetic test that examines chromosomes in finer detail than what can be done by a routine karyotype or chromosome analysis. This means that a microarray can find abnormalities that would be missed by routine karyotype testing. However, it also means that sometimes small abnormalities are identified that are of uncertain significance. Those are the copy number variants of undetermined significance, and may or may not indicate a problem with the fetus. In addition, pretest counseling should include that they can identify large majority of significant abnormalities identified by karyotype, as well as many additional genetic diseases. It can't identify all genetic disorders. Diseases may be identified for which the clinical presentation may vary greatly and range from anywhere from mild to severe, and it may not be possible to predict the outcome in a given patient. The test may identify consanguinity or non-paternity. So patients need to be made aware of that. Genetic changes may be identified that may or may not cause disease. So samples from both parents may be required to help understand the significance of the results. And finally, we need to really drive home that these test results may identify adult onset diseases that will not affect the health during the newborn period or even childhood, but may have unknown severity later in life. So identification of such findings may also indicate that one of the parents has the same adult onset disease, but has not yet developed symptoms. And so that's important for parents to know that they themselves can know through their fetus that they have something that they may develop, but just hasn't exhibited yet. So kind of complex counseling for an array. Next slide, I mean. So Karen, why don't you go through this?
Yeah, so the outcome for this patient, so she did opt for CVS. The karyotype was normal. The microarray, however, showed a deletion, so a copy number variant. And that deletion was at the end of chromosome 5, as indicated in the red circle, and included the NSD1 gene. So NSD1 is a gene that when there is a point mutation within it or deletion, results in a condition called Soto syndrome, which is a condition that is characterized by distinctive facial appearance, variable intellectual disability, and overgrowth. So things that we are not able to detect on ultrasound. So this would be the only way to detect this condition. And then the next patient also opted for microarray. So this is a 37-year-old G3P2 seen at 18 weeks gestation for finding of a left pleural effusion on her anatomy ultrasound. She had low-risk panorama cell-free DNA screening. Family history was notable for some gross motor delays in her 2-year-old son and a question of a neurologic condition in her father, who had been experiencing numbness of his hands and feet, but had been resistant to evaluation. This patient was offered amniocentesis with FISH, karyotype, microarray, infection PCR, and Noonan syndrome panel, which is something we always offer for any kind of fluid collections within the body. This patient would have been offered Vistara, but she was seen prior to its creation, so was not. She opted for amniocentesis and all of the above testing. The karyotype was normal. The microarray did show a copy number variant, however, one that is not at all related to pleural effusion. So in this case, there was a 1.4 megabase duplication at 17p12, encompassing the PMP22 gene. This is the classic finding in individuals who have Charcot-Marie-Tooth type 1A. So that's an inherited peripheral neuropathy. And so in this case, we've diagnosed this fetus with an incidental condition. So the fetus is diagnosed with a condition that may manifest in the sort of teens through adulthood. And that certainly would impact the insurability for this fetus moving forward. In addition, in light of the patient's father's symptoms, we would suspect that he and the patient actually both also have Charcot-Marie-Tooth 1A. The patient denied having any symptoms of the condition and actually took this really hard. And we did refer her for evaluation, and she chose not actually to pursue it at this time. All other testing that was ordered returned normal, negative, and the pleural effusion actually resolved. So this diagnosis was made, and then actually the fetus did well. And now we're going to move over and talk about some more advanced genetic sequencing technologies. And again, we'll start with a case. So this is a G1P0 patient with an unremarkable medical and family history. She and her partner have a shared country of origin, but no known consanguinity. She had a normal first trimester nuchal translucency, first trimester anatomy ultrasound, and then low risk first trimester aneuploidy screening. Her fetal anatomy survey at 21 weeks gestation, however, showed bilateral cleft lip and palate and a borderline left ventriculomegaly. So again, raising suspicion for either a chromosome disorder or other genetic condition. She was offered diagnostic testing, which she did opt to pursue. Her amniocentesis showed a normal karyotype. However, her microarray showed no gains or losses of information, but multiple large regions of homozygosity. So looking at, this is how microarray results are evaluated. So it's all done through software, but this is the printout. So along each chromosome, if there are any gains, they'll be highlighted in green. Any losses will be highlighted in red. And then these purple regions are regions where there's no gain or loss, but they've found that the spelling of the two copies is identical. So they're homozygous or identical regions, which isn't that you usually won't see. So in this case, there were 4 of those, and that would raise concern for recessive condition with a gene in one of those regions. And so I'm going to turn it over to Dr. O'Brien to talk more about the sequencing we would use in this situation.
Okay, so now we're going to go through some concepts of whole genome sequencing and whole exome sequencing. Whole genome sequencing is only done really on a research basis in prenatal diagnosis right now. So what on the left is your standard karyotype, and then you have your microarray, which we talked about, and that's able to detect small deletions or duplications in genetic material. Highlighted in red is the genomic technology or whole genome sequencing, where we literally sequence every intron and exon. And again, that's not really performed except on a research basis, generally in prenatal diagnosis right now, probably in the future, and not too pretty close in the future, I would say. And then we have exome sequencing, so whole exome sequencing. And you see it highlighted in red there, where we walk down every sequence in the exon, which are the protein coding regions of the gene. And whole exome sequencing may identify a genomic abnormality in about 15% of fetuses who have multiple anomalies with a normal karyotype and a normal microarray or both. And so you certainly get an additional yield when you have normal testing in a fetus with one or multiple anomalies. And we are performing whole exome sequencing in a proportion of our cases right now. So whole genome sequencing is better than whole exome sequencing in some cases, and those cases are mitochondrial disorders, copy number variant detection, trinucleotide repeat disorders like myotonic dystrophy, those kind of disorders, and chromosomal rearrangements. Both whole genome and whole exome sequencing are done as trios when possible, so getting both parental bloods and getting fetal material either through a CVS or amniocentesis. Cost of whole exome sequencing is about $2,500 if you self-pay, but a lot of the times we can get this covered by insurance. Whole genome sequencing is a lot more expensive, and again, not really done in prenatal diagnosis currently, and it's about $8,000. The turnaround time has changed significantly. So if Karen and I were giving you this talk even 12, 18 months ago, we would be saying, I don't know, 6 to 8 weeks, okay? But now this turnaround time is about 2 to 4 weeks. So, you know, clinically really able to use whole exome sequencing clinically in order to make decisions about a pregnancy. Next slide. Okay, so when should we be ordering whole exome sequencing? ACOG and SMFM says that we should consider it in patients or fetuses who have one or more major anomaly. We have a highest diagnostic yield, anywhere between 15 to 25% in fetuses with multiple congenital anomalies and a normal microarray. You should also consider it in families who have recurrent fetal phenotypes and no diagnosis, who have a normal microarray. And that's really, you know, we're doing a gene discovery on them at that point. Next slide. So informed consent for whole exome sequencing, as you can imagine, is pretty detailed. You have to describe the test itself, the process, the scope, the potential outcomes, and the alternatives. You have to describe that it's obviously a voluntary test. You have to go through the risks and benefits, the incidental findings, which are even more intense than the chromosomal microarray, and the types of results. So what are the types of results? You can get a positive result, which if you have a positive result on a whole exome sequencing, that result explains the phenotype or the features that we're seeing prenatally. You can have a positive result that is likely pathogenic or a pathogenic result. You can have a negative result, which is genome sequencing that did not find a genetic change that explains a child's condition. And then you can have a variant of unknown significance, or a VUS. That's a genetic change that possibly causes the health problems, but there's not enough scientific proof to know for certain. What are the benefits? The benefits, obviously, if you get a positive result, that can explain the fetal finding. It can tell you the possible prognosis of the genetic abnormality for the fetus or baby. It can improve multidisciplinary care and preparation for the newborn. It can also change the management of the care of that fetus or newborn. You could change the mode of delivery, so perhaps not do a cesarean section and only do a vaginal delivery, or you can change the course and not do intense management, but choose just palliative care. You can change the course of the pregnancy and opt for termination. In a future pregnancy, you can assess recurrence and allow for PGTM or diagnostic testing in a future pregnancy. And then there are certainly the potential for gene therapy in some of these conditions if you identify a potential condition that is amenable to gene therapy. Next slide. Okay, so there's incidental versus secondary findings. So incidental findings are variants in genes that are unrelated to the individual's reported phenotype. Those are just genes that you happen to find, like in Karen's case about the Charcot-Marie-Tooth disease, so unrelated to the phenotype that you find. And then there are secondary findings. So the American College of Medical Genetics has compiled a list of 73 genes causative of disorders with defined phenotypes that are clinically actionable by an accepted intervention. ACGME recommends that variants detected in any of these genes by whole exome sequencing be reported, as they are of medical significance and would be used to inform clinical treatment. For example, BRCA1. You can opt out of secondary findings. So if you don't want to know about these 73 genes like BRCA1, you don't have to opt for these on a whole exome sequencing. But all of these genes, you can do surveillance and early treatment, and they can improve outcomes. Next slide. Okay, so what are the diagnostic yields for whole exome sequencing? For unselected all-comers, the two major studies by Petrosky is one of them, shows about a 10% yield in unselected population, and the Page study about 8.5%. So between 8 and 10%. In unselected patient populations with multiple anomalies, upwards to 15 to 20% for the two major papers. What about an isolated increased NT? So what if you have a patient that comes in and says, well, my karyotype and my microarray were normal when I did my CVS for my increased NT. What other genetic tests could I do? And they come in, they're pretty savvy. They asked about whole exome sequencing. It's really minimal. You're only going to get a yield of about 1 to 3%. Okay, so it really depends on what you're seeing on ultrasound in terms of what the yield for whole exome sequencing is.
Okay, so going back to our patients, they did have whole exome sequencing performed on fetal cells from the amniocentesis. And in this case, a cause was found. So you can see the result is positive, that there were no other findings, no secondary findings. In this case, secondary finding was declined by the couple. And so what they found is that the fetus is homozygous for a pathogenic, so as a sort of more definitely disease-causing variant in the TMC01 gene, and that's associated with TMC01 related neurodevelopmental disorder with multiple anomalies. So this is a really rare condition that we would not have thought of otherwise on our own without doing exome sequencing, but fit very, very well with the phenotype for this fetus. And the fetus is homozygous, meaning has two of the same variant, so one from the mother, one from the father, which is also on this report because it was done as a trio analysis. So this was really helpful in being able to give the couple insight as to what the expectations will be for this fetus, sort of as it moves through its life. They were offered the option of ending the pregnancy and opted to continue, and it really did also help in the newborn period to know what we should be looking for other anomalies as well. So it's certainly helpful in that situation. I will say though, as provider, I feel like exome is in some ways disappointing in that, you know, you're looking through all of the exomes, all of the protein coding regions, and the yield is sort of at best 30% in situations where you really expect there to be a genetic answer. So we are hopeful that as science progresses and we identify more genes and learn what they do, that will improve. So where do we see things going from here? So I would say the next several things on the horizon. One would be research into identifying fetal cells or using fetal cells that are in the circulation for diagnostic purposes. And this would help to avoid the potential for false positives that we see in cell-free DNA analysis related to placental mosaicism. So to get more directly at the fetus. I think that there'll be, movement towards more personalized cell-free DNA for single gene conditions. So much in the same way that we can do Vistara for a specified panel, being able to do that for a particular family based on the condition that's in their family that isn't on the Vistara panel. I think we'll see expanded use of whole genome sequencing. There's always a trickle down. Things happen in peds first, and then they trickle down to prenatal. And whole genome sequencing is happening quite a bit in the last, I would say, 6 months to a year in pediatrics. And so I think we'll see that shift to prenatal as well. And then, as Dr. O'Brien said, I think there's going to be a lot more work on fetal gene therapy as well. So, you know, there are certain conditions that, for instance, spinal muscular atrophy, that there are these treatments that are sort of in the vein of gene therapy, if not gene therapy. And in certain conditions, the sort of phenotype is starting in utero. So being able to move that treatment earlier into the fetal timeframe could be of benefit. And I think we'll see more work on that as well.
Absolutely. All right. So I just wanted to thank everybody for attending. Thank you, Karen. And I just wanted to shout out to our prenatal genetics team here at BI. Dr. Millie Ferris is also an MFM geneticist with me, and we have a wonderful group of genetic counselors. Karen Marchand is the senior genetic counselor who leads a wonderful team of genetic counselors, Nicole Paulos, Paula Delarmy, Lisa Pellegrini, and Davia Scipio. There is a email address, prenatalgenetics@bidmc.harvard.edu. If you have any questions, you could always email us. And our door is always open. So if you have any questions, please put them in the question and answer or in the chat, and we'll be happy to answer them.
Thank you. This was wonderful. And if anybody has any follow-up questions, the contact information is still up here on the screen. And then this recording will be posted on the MFM YouTube playlist shortly. But thank you all for joining tonight. And thank you again, Karen and Barbara, for this amazing presentation.
Excellent. Well, have a good night, everybody. Thank you.